So I'm Tim McHenry. I'm an orthopedic spine surgeon at the Southeastern Neurosurgical and Spine Institute. And we're going to go over the basic cervical spine physical examination. Now, there's going to be a basic examination showed, and it may show some abnormal findings. And if it does, there's going to be some other tests that we can do. We may show some of those, but in general, this is a very basic and hopefully normal examination on the patient. So the first thing we do is take a look at alignment. Okay, so he's head's over his shoulders, shoulders are level. He's got lordotic alignment of his cervical spine, clinically. Okay, any pain when I palpate along there? No. So no midline tenderness. Any pain in the sides? So no paraspinous tenderness. Okay. Check range of motion. So flex forward for me as far as you can, okay? And look up as high as you can. So flexion and extension, and that's full. Look straight. Now turn all the way that way. Turn all the way towards me. And look straight ahead again. And tilt all the way that way, and tilt all the way towards me. So again, full range of motion with a normal arc and no discomfort. Okay. Next, we're going to do some functional testing. Show me your hands. Close them. Open them. Go as fast as you can, opening and closing them. Okay, so a patient should normally be able to open and close fully 20 times in 10 seconds. Okay, less than that may indicate myelopathy. You can stop. May indicate also there's other causes such as rheumatoid hand or arthritis you need to consider as well, which may limit that testing. Then hold your hands out, squeeze your fingers together, and again, a patient should be able to maintain fingers closed, and if his small fingers start drifting out, that can indicate some weakness associated with myelopathy. Okay. Test Hoffman's reflex, which is passive flexion of the DIP joint of the long finger. And normally, people don't have a reflex, but some patients have reflexive flexion of the thumb and the DIP of the index finger, which may indicate hyperreflexia and, again, myelopathy, but it also can be normal in some patients, particularly if they're hyperreflexive from underlying medical conditions such as hyperthyroidism. Okay. So we'll do motor testing now. So we'll do shoulder abduction, primarily C5, elbow flexion, primarily C5, wrist extension, primarily C6, elbow extension, primarily C7, grip, primarily C8, and finger abduction, primarily T1. And he's full strength in all those motor groups. Then for sensation, C5, normal, C6, C7, C8, and T1. So that's the lateral elbow, the thumb, the long finger, the small finger, and the medial elbow. Reflexes we can check are biceps reflex, C5, brachioradialis reflex, C6, triceps reflex, C7. And he's normal in all those distributions. Some abnormalities we can find are an inverted radial reflex with a brachioradialis reflex. Watch his hand. And that's a reflexive flexion of his fingers, which may indicate myelopathy. Cross hip adductor reflex, which is not normally present, but watch his left leg, which may indicate myelopathy. See how he internally rotated his hip. And humeroscapular reflex, tapping on the spine of the acromion and causing reflexive shoulder abduction. And again, that may indicate myelopathy. Another important thing to consider with cervical spine disease is shoulder pathology. A lot of times they overlap. Pain here in your shoulder? No? Okay. Okay. Raise your arm up over your head. Okay, any pain there?
No pain.
Any pain with this? That's Neer's maneuver. Any pain here?
No.
Hawkins maneuver. Okay, point your thumb to the floor, push up as hard as you can. Okay, no weakness there with scaption. Rotate your hand out. No weakness with external rotation. Now reach up behind your back as high as you can. Okay, and he has good internal rotation. Any pain there?
No.
No, okay. And then finally, patients can have coexisting or compression neuropathy instead of neck problems. Any tingling when I do that? So I'm percussing over the cubital tunnel.
Mm-hmm. No tingling.
Percussing over the carpal tunnel. Any tingling?
Mm-mm.
Okay. Any tingling in your fingers when we hold this position?
No.
It's an elbow flexion test for cubital tunnel syndrome. Any tingling in your fingers when we flex your wrist? And that's Phelan's test.
Mm-mm.
Okay. And both the elbow flexion test and the Phelan's test may need to be maintained for up to a minute to elicit abnormalities. And that concludes the neck examination.